Welcome to another deep dive. And usually when we talk about healing from a medical procedure, there's like this built-in expectation of visibility, right? You expect to see the healing.
Oh, absolutely. We're very visual creatures.
Yeah, exactly. Think about, I don't know, patching a tire or getting a cut on your arm that needs stitches. You actually get to physically watch the skin knit back together.
Right, you see the redness start to fade, you watch the scab form.
Exactly. And you just know day by day that you're on the mend. It's comforting because you have visual proof that your body is doing its job.
We rely so heavily on our eyes to tell us that everything is going according to plan. Having a visual timeline naturally lowers our anxiety.
But the moment you step into the world of internal, non-surgical gynecological procedures, that visual roadmap completely vanishes. You just can't see it.
It's totally gone. You're completely in the dark.
Right. You're left relying on basically a stack of clinical guidelines and NHS patient leaflets to decode what your body is doing, which is exactly the mission for today's deep dive.
It's a really important one, too.
It really is. We are tackling a very specific and honestly a very stressful question for anyone going through this. When is spotting or light bleeding considered unusual after a non-surgical treatment session?
Because it's not always obvious.
No. Going through these medical overviews, there's this huge murky gray area between what is, just normal internal healing and what is a flashing red flag.
It's a vital distinction to make. I mean, we're talking about incredibly common, highly effective outpatient procedures here. Things like cold coagulation, LATZ, and endometrial ablation.
Which so many people have done every single day.
Exactly.
Yeah.
But because they happen internally, they temporarily alter your body's delicate ecosystem. So the goal today is to build a clear physiological roadmap for you, the listener.
Because you can't just look in the mirror to check it.
Right. When you can't look at a wound to see if it's infected or healing well, you have to rely on secondary signals. And the primary signal the body uses after these specific procedures is discharge and bleeding.
Which is terrifying if you don't know what to expect.
Completely. But understanding the biological why behind that bleeding takes away the panic and, replaces it with informed observation.
Informed observation. I really like that phrase. So before we can even begin to spot what unusual bleeding looks like, we have to establish a baseline for normal, right?
We have to know what we're comparing it to.
Exactly. We need to look at the actual mechanics of healing. Let's start with treatments on the cervix. The clinical sources detail procedures like cold coagulation, which, by the way, despite the name, actually uses a heated probe to burn away abnormal cervical cells.
Yeah, the naming there is a bit counterintuitive.
Totally. And then there's LLETZ, which stands for large loop excision of the transformation zone. That one uses a tiny electrified wire loop to essentially shave off the abnormal cells.
Right, so in both of those cases, the doctor is intentionally leaving an open wound on the cervix.
A deliberate wound.
Exactly. They are removing precancerous or delicate, easily bleeding cells, specifically to allow stronger, healthier tissue to grow back in its place.
But the immediate aftermath is, as you said, an open internal wound.
Yes. And the cervix is a highly vascular area. I mean, it has a very rich blood supply, which means it's prone to bleeding even under totally normal circumstances.
Well, the numbers in the clinical overviews really back that up. I saw a stat that said something like 85% of people experience bleeding after a LATZ procedure.
85%, that's almost everyone.
Yeah. The guidelines state it is entirely normal to have watery, blood-stained, or even brown discharge for up to 4 full weeks.
4 weeks is a long time to be spotting.
It is, and when I was trying to conceptualize this, the best analogy I could come up with was a bad burn on your hand.
Okay.
You know how a burn kind of weeps and oozes that clear fluid while the new tender skin forms underneath? It feels like that's what's happening here, just internally, mixing with everything else.
That's a great way to think about it. The biology of it is remarkably similar to that burn on your hand. Your body is rushing fluid, white blood cells, and healing factors to the site of the thermal injury or the excision.
It's sending in the emergency response team.
Exactly. And inside the vaginal canal, that weeping fluid mixes with normal cervical mucus and trace amounts of blood from those tiny exposed capillaries.
So it looks a bit messy.
It does. Essentially, your body is forming a soft scab over the cervix.
Yeah.
But a scab inside a moist mucus environment behaves very differently than, say, a dry, crusty scab on your scraped knee.
It doesn't get hard and crusty.
No, it stays soft and it's going to be a bit messy as it forms. But as long as the resulting discharge or bleeding is lighter than or roughly similar to a normal menstrual period, you are just looking at standard healthy tissue repair.
It's just the invisible work of the immune system, the body sending out the construction crew. But then, right when a patient might feel like they've got a handle on this weeping healing phase, here's where it gets really interesting.
Oh, the plot twist.
The plot twist, because the clinical literature highlights a very specific moment where normal healing suddenly disguises itself as a terrifying complication. It happens right around the 10-day mark post-treatment.
The infamous day 10 shift. It catches so many patients totally off guard.
I can imagine. Out of nowhere, around day 10, the bleeding might suddenly spike. It gets much heavier. And the leaflets specifically warn that the discharge might change texture entirely and start to look like coffee granules.
Yes, coffee grounds.
No, I have to push back on this a bit. Because if I'm a patient and I've had light, watery spotting for over a week, and then suddenly on day 10 the bleeding surges and looks like dark coffee grounds, how am I supposed to know that a dramatic increase in bleeding isn't a massive complication?
It's totally counterintuitive.
It feels inherently wrong, like a stitch popped or the wound just burst open.
It's incredibly alarming, and honestly, that's exactly why doctors watch for it and try to warn patients ahead of time. What's fascinating here is the underlying cellular timeline.
Okay, break that down for me.
Let's go back to that soft, messy scab we talked about forming over the cervix. It takes roughly a week to 10 days for the healthy new skin cells to fully proliferate and build a secure foundation underneath that temporary barrier.
So the new skin is ready.
Exactly. Once that new tissue is relatively stable, the body doesn't need the scab anymore, so it begins to actively shed it.
Oh, wow. Wait, so it's not a fresh rupture at all. The coffee granule appearance is literally the old scab breaking apart and leaving the body.
That is the physical material you are seeing, yes. It's dark and grainy because it is old, oxidized blood that has been sitting there doing its structural job for over a week.
And blood gets darker the longer it sits.
Right. The acidic environment of the vagina naturally darkens blood over time. So the sudden increase in volume is simply the bulk of that temporary bandage coming away all at once.
That makes so much sense.
And sometimes, as that scab detaches, it tugs slightly on the newly exposed, very tender capillaries underneath, which can add a tiny bit of fresh, bright red bleeding to the mix. It looks terrifying, but it is the ultimate sign of progress. The wound is graduating to the final phase of healing.
Okay, that completely reframes the anxiety of day 10. It's a shedding, not a hemorrhage. But that brings us to the most critical part of this deep dive. Because we've established that watery discharge is normal. 4 weeks of light spotting is just the body repairing itself. Even a sudden cocky ground surge around day 10 is part of the plan.
It's all part of the blueprint.
Right. So when does bleeding actually cross that invisible line into the danger zone? Okay, let's unpack this. Because the NHS leaflets and the medical guidelines are incredibly strict about the absolute red flags, they really don't leave much room for interpretation.
And for good reason, you know?
Yeah.
When complications do arise, they require swift medical intervention.
Yeah, so the first major red flag is volume. The universal rule across the sources is the pad an hour rule. If you are soaking through a standard period pad every hour for more than 2 hours, you are in unusual territory.
Some of the literature refers to this as delayed hemorrhaging.
Right. Second is duration. We mentioned the 4-week rule for standard healing. Any spotting or bleeding that persists beyond that 4-week mark is officially unusual.
The clock is ticking on that one.
Yep. And third, and perhaps most importantly, are the accompanying symptoms. If the bleeding, regardless of how light or heavy it is joined by a foul, offensive smell, a yellow or green discharge, a high fever, or severe, ongoing lower abdominal pain.
That is an immediate stop what you're doing and call a doctor situation.
Absolutely. No waiting around.
If we connect this to the bigger picture of how the body functions, those red flags paint a very clear picture of a biological process gone wrong. Let's look at those accompanying symptoms first. The offensive smell, the high fever, the yellow discharge.
Those definitely sound like infection.
They are the classic hallmarks of a bacterial infection. The vagina has its own complex microbiome, right? A very delicate balance of native bacteria.
Right, regulates itself usually.
Exactly. But whenever you introduce an open burn or excision to that environment, there is a small risk, usually less than 2%, according to the data, that opportunistic bacteria will colonize the healing, vulnerable tissue.
Okay, that makes sense for the fever and the smell, but how does an infection actually trigger the heavy bleeding? Like, why does a bacterial issue suddenly cause someone to soak a pad every hour?
It comes down to inflammation.
Oh, interesting.
Yeah, when an infection sets into the healing skin of the cervix, the body's immune system triggers severe, localized inflammation to fight off the invaders. And inflammation physically dilates or opens up the surrounding blood vessels to bring more white blood cells to the area.
So it's purposefully opening the floodgates.
Yes. Yeah. And on top of that, certain aggressive bacteria can actually produce enzymes that break down the newly formed tissue and dissolve the clotting factors the body has put in place.
Oh, wow. So they're destroying the repair work.
Right. So what was just a light, weeping capillary trying to seal itself shut suddenly becomes a wide-open, unprotected vessel actively pouring out blood.
The bacteria are basically undoing the healing process, forcing the plumbing wide open.
That's a great way to put it.
And that's why the guidelines are so firm that you can't just wait it out at home. You need antibiotics to actively kill the bacteria so the vessels can finally close back up.
Yes. The infection fundamentally disrupts the structural integrity of the wound. And, regarding the duration red flag bleeding past 4 weeks, it operates on a similar principle.
How so?
Well, even if it isn't a raging bacterial infection causing a fever, bleeding at week 5 or week 6 indicates that the cervical tissue is caught in an inflammatory loop. It is failing to completely seal over.
So the body's just stuck in the repair phase.
Exactly. In both the hemorrhage scenario and the prolonged duration scenario, a doctor needs to physically examine the area. They might prescribe antibiotics, or they might occasionally apply a specialized Saver nitrate solution to manually cauterize and stop a stubborn bleeding vessel.
Got it. So for that first month, context is everything. You're tracking volume, smell, fever, and the calendar.
It's all about the data points.
But we've only been talking about the surface of the cervix. What happens when the healing has to happen deeper inside the body? Let's move up into the uterus itself.
Okay, let's go there.
Because I noticed a whole other category of non-surgical procedures in our sources where the rules of recovery are completely flipped on their head.
Yeah.
What if unusual spotting or bleeding occurs months or even years after a procedure?
That requires a totally different framework.
Let's shift the focus to endometrial ablation. Unlike LLETZ or cold coagulation, which are targeting tiny, specific precancerous cells on the cervix, an ablation is a much broader, more aggressive procedure, isn't it?
It is. It's specifically designed to stop or severely reduce heavy menstrual bleeding by completely destroying the inner lining of the womb, the endometrium.
Right. Doctors use heat, radiofrequency, or a heated balloon to essentially burn away the tissue that builds up and sheds every month during a regular period.
The clinical goal is to create a purposefully scarred, inactive uterine cavity so that heavy menstruation is no longer physically possible.
And the success rates are really striking.
Yeah.
The clinical data shows that 91% of women see significantly reduced bleeding, and 41% stop having periods entirely.
The bleeding just stops.
Exactly. Therefore, if a patient has an ablation, goes through the initial few weeks of healing, and then heavy bleeding somehow continues. Or if totally new spotting begins long after the recovery window has closed, it is highly unusual because the source of the bleeding was supposed to be gone.
Right. This raises an important question. If the uterine lining, the very tissue responsible for menstrual bleeding, has been deliberately destroyed and replaced by dense scar tissue, where exactly is this new bleeding or this severe cyclical pain coming from?
Right. If you burned away the source material, how is the symptom coming back?
This brings us to a complex phenomenon heavily documented in the medical literature known as LOEAF.
LOEAF.
Yes, which stands for late onset endometrial ablation failure.
This part of the research was absolutely fascinating to me. It dives deep into the mechanical complications and the anatomical paradoxes of the female reproductive system.
It's a real puzzle.
It is. Building directly on this idea of Loyer, the sources mention these incredibly specific, almost engineering-like failures that cause this unusual late-stage bleeding. Conditions like hematometra, Asherman syndrome, and Pate-SS post-ablation tubal sterilization syndrome.
They all share a common physiological root cause based on how the reproductive organs communicate with each other.
Okay, let me run an analogy by you because I really had to visualize the anatomy to grasp this.
Go for it.
The ablation procedure purposely causes scar tissue to line the uterus. At first glance, you'd think, isn't that a good thing if the goal was to stop the bleeding? Why is this purposeful scarring suddenly causing intense pelvic pain and unusual spotting 3 years later?
Right, it seems contradictory.
So the best way I could understand it is to imagine a house where you've boarded up all the doors and windows from the inside so absolutely nothing can get out, but you forgot to turn off the water pipes inside the walls.
Yes.
Huh?
I love that analogy.
Mhm.
And in this anatomical boarded-up house, the water running is driven by your ovaries. This is the crucial disconnect that often causes confusion for patients. Endometrial ablation only destroys the lining of the uterus. It does absolutely nothing to the ovaries.
So they're still going.
Your ovaries are completely unaffected by the heat or radiofrequency, which means they are still cycling. They are still releasing estrogen and progesterone every single month, like clockwork.
Just doing their normal job.
Exactly. They are still sending powerful hormonal signals to the uterus, commanding it to build a lining and then shed it.
See, the body is actively trying to menstruate even though the machinery is broken.
That is the paradox. In some cases, tiny microscopic pockets of endometrial tissue manage to survive the ablation deep within the muscle wall, or the tissue slowly regenerates in small patches over the years.
And they respond to those hormones.
Yes. When those monthly ovarian hormones hit those surviving pockets of tissue, they bleed. But because the main cavity of the uterus is now blocked by heavy scar tissue, the boarded-up doors in your analogy, that blood cannot simply flow down and exit the cervix like a normal period.
Gets trapped inside the house.
It gets entirely trapped. And depending on where it gets trapped, it creates different syndromes. If that scar tissue essentially glues the walls of the uterus together, that is what we call Asherman syndrome. There's no space left.
And if there is space.
If the blood pools behind the scar tissue inside the main body of the uterus, expanding it like a balloon, it's called hematometra.
That sounds incredibly painful.
It is. The uterus cramps violently trying to expel this trapped fluid, causing intense chronic pelvic pain that mimics the worst period cramps imaginable, but with little to no visible bleeding.
Because it can't get out.
Right. And if that trapped blood has nowhere to go down, it takes the path of least resistance and backs up into the fallopian tubes, expanding them painfully, which is called hematosalpinx.
And, okay, if the patient previously had her tubes tied like a tubal ligation, the blood is blocked at the bottom by the uterine scar tissue and blocked at the top by the tied tubes.
Exactly. And that specific anatomical trap is what causes PATSS, post-ablation tubal sterilization syndrome. The blood is entirely confined, stretching the delicate anatomical structures to their absolute limits.
So where does the spotting come from then?
Eventually, as the pressure builds month after month, this trapped fluid might force its way through tiny fissures in the scar tissue, resulting in unpredictable, unusual spotting months or even years after the procedure. It is the body's internal plumbing backing up and leaking under pressure.
It's incredible when you visualize it like that. The spotting isn't a new period, it's an overflow warning.
That's exactly what it is.
So what does this all mean? If you are sitting there listening to this deep dive and you've recently had one of these procedures, or maybe you had one years ago, how do you navigate these murky water?
You have to be a bit of a detective.
Right. It all comes down to the fact that when evaluating bleeding, context is absolutely everything. You have to look at the timeline. If you had a cervical treatment like LLETZ, are you before or after that 4-week mark? Is the volume passing the pad an hour rule?
Are there those red flag accompanying symptoms like a high fever, foul smell, or severe pain?
Yeah. That is the key to distinguishing a messy day 10 scab shedding from a true bacterial complication.
And if you've had an ablation, understanding that the absence of a period doesn't mean the absence of a hormonal cycle is critical. Any new persistent spotting or severe cyclical pelvic pain occurring long after the procedure warrants medical investigation.
Because as we've discussed, it's a mechanical issue of trapped fluid, not a failure of your body to heal initially.
Exactly. It leaves us with a rather profound physiological thought to ponder, I think.
What's that?
Well, these non-surgical treatments are incredible feats of medical science, right? They are exceptional at managing our health and preventing disease from progressing. But they inherently alter the body's natural communication methods.
Because they change the way the body operates.
Right. Historically, a heavy period or persistent bleeding was the body's loud, unavoidable distress signal. If a medical procedure artificially silences that primary alarm system, the question becomes, how do we adapt?
Oh, that's a really good question.
How do we learn to listen to the new, much quieter, much more nuanced alarms, like a subtle change in discharge on day 10, or a dull, cyclical ache years down the line that our bodies might be desperately trying to send us?
That is something to think about, learning your body's new language. Well, that wraps up today's deep dive. Thank you so much for joining us, and we'll catch you on the next one.